Okay, what a great day it is. I am really looking forward to this. Suzanne and I, Suzanne Fagel, my
Hi.
partner in crime and co-partner and director of Tapping Out of Trauma Continuing Education, webinars, and classes. And I'm going to introduce you to our special guest in a second. We do these twice a year, which we love doing. It's a way to be of service, to help keep educating practitioners or people that are interested in being more trauma informed. Um, Different perspectives of working with trauma, different perspectives on the impact of trauma, and basically anything that has to do with trauma. That's kind of the theme here. So for this time, I'm going to go ahead and introduce. We're talking about EFT. We're talking about trauma. We're talking about how they are in relationship with addictions, and we have really just the best expert I could think of creating for this. And so I want to introduce you to Dr. Adriana Popescu. And she's a clinical psychologist. She's also an empowerment coach, definitely a speaker, an awesome author. We'll talk about that. She's a podcast host as well with like 25 years of experience in the mental health field as a clinician. She specializes in treating addictions and trauma. That's why she's here. She's directed a number of treatment programs in the San Francisco Bay Area. She's the founder and CEO of Firebird Healing, which is a trauma healing program, and the clinical director at Avery Lane. And that's a holistic treatment center and program for women that have co-occurring disorders with trauma. Her book, What If You're Not As, I can say, effed up as you think you are, was released in 2022. Love that. She's got a private practice in San Francisco. She travels around the world speaking, coaching, facilitating workshops, and publishing addiction and EFT research, which we need so much. And that's how I first heard and read about her. And now we get to have her here. So welcome, Adriana.
Thank you so much, guys, for having me. I'm happy to be here today.
Yeah, this is awesome. And, while we have a module about trauma and addiction in our level 2 course, our advanced course, we haven't done one of these webinars, and we certainly haven't done one with you. So here we are, because it's so important. And I think we just want to, we were talking and let's just kind of start off softball kind of question, but it's an important one. Could you just let people know a little bit about yourself, how you came into the field of mental health, but especially addiction, and really your relationship with energy psychology, EFT, and addictions? That's really important for most of our viewers here. So maybe you could just give us a little background about yourself that way.
Sure. And if I go on and on, by all means, please let me know,
Okay.
because once I start talking, I can keep going. But basically, I was oriented to helping professions very young. My dad was a doctor, so I kind of grew up with that ethos of wanting to be there to serve people, help people. Drawn to psychology and wanting to be a therapist in particular because of my own early life traumas and
Mhm.
experiences, things I went through that I felt I didn't have support for. No one was there for me. No one had gone through some of the things I had gone through. I was always the first kid whose parents got divorced, the first kid who had a parent die, the first kid who had this or that happened. And then once I went through it on my own, then my friends would start having these things happen and they would come to me. So I was always the go-to for support and advice. So I was like, this seems like a good career path. Let's go this route. I had a very traditional undergraduate Ivy League kind of education. That was all great. I learned a lot about traditional psychology. And then my own life took a dramatic turn post college when I was living in Colorado and I became really sick.
Okay.
And it was very mysteriously ill. Doctors at that time could not figure. It took them 13 years to actually figure out what was wrong with me. Was that I had Lyme disease and chronic fatigue syndrome and all the kind of co-occurring things that come with that. And, at that time, this was the 90s, Western medicine really didn't have much to offer. So I had to pursue my own healing. I knew I could heal from this, even though the doctors were telling me, no, the best you can do is learn how to manage this disease. But I knew better. And so I sought out alternative therapies. I mean, it started with going to massage therapy school in Colorado so I could learn more about bodies and energy and because I was kind of from the head from the head up only. I didn't realize I had a body, and so I learned about that, and I learned about chiropractic and starting seeing more holistic practitioners, acupuncture, and then it was two things that happened at once. I'm in grad school. I eventually made my way to California and enrolled at the Institute of Transpersonal Psychology. So I was pursuing my PhD, and I found a flyer in the student lounge one day for I think it was the second annual ASAP conference. So
Mm-hmm.
it's right around 1999, 2000. And I just knew I had to be at that. So that was my first
Excuse
experience.
me, for those who might not know, what does
Oh,
ASAP stand
yeah.
for?
The Association for Comprehensive Energy Psychology. It's kind
Thank
of
you.
the umbrella organization overseeing all things EP, energy psychology, EFT research, humanitarian efforts, all different kinds. It's the sort of central location to go for all things EP. So I went to the first, conference that I'd been to of theirs, and my whole universe just blew open. Meanwhile, I was working with an acupuncturist who was learning NET, neuro emotional technique, which is, I would say a cousin and sort of falls under the broader energy based therapies. And she was working with me on my Lyme disease and working through all these old traumas that I had been through, that had never been dealt with, that were playing a role in my illness. And so it was kind of both, curiosity academically and then also experientially. And then I started using these different tools. EFT was one of them, in my own healing process. And then, of course, I wanted to start, as I was doing internships and working with clients, I wanted to use these tools with my clients. The addiction piece came when I started doing practicum and internship work. Some of it was pragmatic. Like, it seemed like there were always jobs available for therapists and rehab programs. And then I had personal experience, not of my own per se, but so many of my friends and loved ones had struggled with addiction. So I felt like this is familiar territory. So it all kind of came together, and I liked doing the work. I liked specifically the dual diagnosis co-occurring, working both with the mental health and the substance use. And then, of course, having this more holistic body, mind, spirit perspective. I just kept going, and here we are 20 some years later.
Right.
Awesome.
And now you founded the Avery Clinic, and you're using a lot of those. Tell us a little bit more about the clinic and the different tools it uses. And yeah.
So yeah, I was really fortunate. I've been with Avery Lane for almost 7 years now, since it was an idea in our founder Camille Hildebrand's mind. She had this vision for creating a healing center for women, that specialized in treating trauma. And at first, she asked me, "Hey, she knew my work with energy psychology. She's like, would you like to run a group for this rehab I'm going to open?" And I said, "Yeah, that sounds great." And she goes, "Oh, and by the way, we need a clinical director. Could you be our clinical director as we get started until I can hire someone full time?" Because she knew my work from other treatment programs. She'd worked in addiction treatment, as had I, and we knew each other, and she knew my work. And I said, "Sure, I'll be your temporary clinical director." And 7 years later, and I'm still the clinical director. And what we do is we essentially address substance use disorders. That's the type of addiction we work with. So of course, people have secondary and other kinds of addictions, but the focus has to be on substance use disorders. And then they usually have a co-occurring mental health diagnosis, most often some kind of anxiety disorder, a mood disorder, and PTSD. Most of our clients have post-traumatic stress disorder. We do all of the kind of gold standard therapies that regular addiction treatment programs would have, like CBT, DBT, motivational interviewing, relapse prevention. IFS is a big topic right now. Internal family systems, we're using that. A modality called conscious recovery that we can talk about. And then the EP piece comes in a few different ways. One, we run energy psychology groups. I and other therapists that I've trained have a weekly group in our residential programs. And we do have a new mental health primary as well. We have our substance abuse primary and a mental health primary. So all of those programs are getting a weekly group on energy psychology. And then the outpatient program also has a group. So we've basically got 4 groups a week running with different facilitators, including myself, where we're teaching the clients how to tap. Sometimes we do a little bit with Be Set Free Fast. I was really drawn to that modality early on and wrote my dissertation on it. But primarily EFT. And we're teaching it as an emotional self-regulation, kind of the emotional first aid tool, how to like calm your nervous system, how to get out of a fight, flight, freeze response. We teach it to the clients to use themselves as a tool
Great.
in lieu of drugs and alcohol to like calm yourself down.
So
Um,
good.
and then the deeper work often will happen, the deeper trauma processing or working with the core false beliefs that they have about themselves or whatever the deeper issues are in the one-on-one therapy. I train all the therapists in how to use tapping in that kind of way, kind of like what you guys are doing with tapping out of trauma. We also use brain spotting. I really liked brain spotting when I learned it at an ASAP conference. And so we get all our therapists trained in brain spotting, and that's how we do some of the more the kind of addressing more the root causes of their addiction.
That actually takes me to my next question is, we're speaking about the comorbidity, the overlap, et cetera. Let's talk about, I guess we'll call it like the traumatized brain, the addictive brain, right? And how they maybe got to each. Are they the same thing? Are they different? Do you always see, is everybody with substance abuse, is there always trauma? Not everybody with trauma necessarily has addiction. So could you just kind of speak to, from your perspective, how those interrelate?
Yeah, I mean, there's a huge overlap. And I honestly think the statistics, I don't know how they do their research, and get these numbers sometimes. But I think the statistics kind of underreport how much overlap there is between trauma and addiction based on those of us that work in the field. I think I would say probably about 90% of the clients that I have seen, not just at Avery Lane, but at any treatment program I've worked at for addictions, 80 to 90%, but closer to 90, have some kind of traumatic experience in their background. And maybe the drugs and alcohol became a way to cope with that. Um, so that's huge. Probably if you went the other direction, how many people who have trauma have developed an addiction, that those numbers might be lower. But if they have an established substance use disorder and another kind of addiction, it's quite likely they have the trauma in the background. And the conventional old way of treating trauma and addiction treatment was you don't even touch the trauma for 6 months to a year of sobriety. You wait until the person, you get them sober, they get going with their tools, and then you do the deeper work. Except what we see is that our clients can't put together 6 months to a year sober because of the severity of their unresolved trauma, because their brain, I will get to the brain part, their brain is still like on fire with trauma and they can't stay sober. So we actually address the deeper trauma processing earlier in treatment, which maybe is somewhat controversial, but I think our field in general is going more in that direction as more and more programs hire licensed mental health professionals. It used to just be peer counselors, other people in recovery. We still have them working in treatment, but more programs now do have the trained mental health professionals and psychiatrists so they can do the meds and things. So you are seeing a trend and you're seeing more trauma informed. You're seeing EMDR and brain spotting slowly starting to make their way into programs. But really, a traumatized brain and an addicted brain look remarkably alike. And essentially, the main piece of that is the amygdala, the emotional center of the brain, the part that is, deciding if there's danger, are we safe, are we in danger, and then activating that fight or flight response or the freeze response. And then, people have learned that this is how I cope with this is with some sort of addictive behavior. So unlearning that and rewiring people's brains is a big part of addiction recovery. And I think also trauma recovery, because you've got an overactive amygdala that's constantly being activated and people are in a constant state of fight or flight or freeze, or they're alternating, between the two.
Right.
Yeah.
And along that same line, if we can just refine this a little bit more even, a lot of practitioners are probably not aware of stages of presentation in addiction. So how do levels of readiness show up differently as clients progress in their treatment? And how is addiction treatment a process of relapse and recovery?
So the thing you want to know here is the trans-theoretical model of change, right? Prochaska and DiClementi's work from back in the 80s. where they were actually looking at working with people who were quitting smoking and cigarette smoking, and realizing that it isn't just a clear process from I'm going to quit smoking and now I've quit smoking. Like, it's not that linear. People go through stages of readiness, and they can go back and forth between these stages, and they can cycle through them. And so the stages are pre-contemplation, contemplation, preparation, action, maintenance, and relapse.
Can you talk and explain each of those a little bit more?
Yes.
Yeah,
And
great.
and really what I want to say is your interventions, and this is actually true not just for addiction. These stages of change are actually true for any kind of change. Like, I've been looking to move out of the city of San Francisco for a while, but I've been in contemplation around it for years. So in pre-contemplation, you don't recognize there's a problem. Like, I'm perfectly content living in the city, or my drinking is not a problem. I'm totally fine. There's no recognition of any kind of problem. Even if other people might be seeing there's a problem, you don't think, you're not ready to change. You're not even considering a change. Contemplation is, maybe I do have a problem with my drinking, or maybe the city isn't really working for me anymore, but you're on the fence. You're back and forth around whether I'm going to make the change or not. Preparation is you've made the choice to make the change, and now you're getting ready to change some things, get some help, figure it out. Action is you're taking the action steps. And then once that you've been in action for 6 months or so, maybe longer, maintenance is like the ongoing maintaining of the change. And relapse, of course, can occur at any point in this process. Once you've already, it really is more relevant to the preparation and action and maintenance stages, because at that point you have made the choice to quit the behavior, but you've relapsed on it. If you're in pre-contemplation or contemplation, you haven't yet even chosen to make the change. And so your interventions really have to match the stage of change.
Right.
You can't tell someone in contemplation or pre-contemplation, hey, you need to attend 90 meetings in 90 days. What does that mean? I'm going to go to AA every day? I don't even have a problem. I'm not like those people. That intervention isn't going to work. Trauma processing, so getting too soon into trauma processing when someone yet doesn't even recognize that they've had a trauma. They don't think of the abuse they went through as traumatic. They don't understand what trauma is. You can't go there yet with that person, right?
That's right. I just want to highlight that for a moment and pause. I mean, it's a great discussion. And it's really important because I think, benefiting from bringing different models like this from outside the EFT world into EFT can be really important. And why not stand on the shoulders of other therapies that have found working models? And so, for example, somebody that comes to an EFT practitioner, sometimes I see the practitioner leading somebody into the trauma work when it really wasn't the idea of the client, when they may not be ready, it was too early, but the practitioner hears, ooh, that must be the source of that, and maybe it is. Right. And then they dive in too quickly. In many other trauma-informed therapies, and according to the model you're saying, it's like, hold on a minute.
Yes.
It's almost like they need to bring us there. They need to be making that connection. They need to be in a state of readiness and resourced enough to be able to go there.
Right.
And too quickly can be harmful and can really kind of explode the process. Right.
And motivated to go there too.
That's it. Right.
Well, and motivational interviewing really goes hand in hand with the stages of change. They're always taught together, when we teach counselors and therapists about this. So really recognizing the Miller and Rolnick work with motivational interviewing, where you're asking, you're coming from this neutral kind of, unconditional positive regard stance, and you're coming neutral without a real obvious agenda. And you're asking the client a lot of questions. Okay, well, tell me more about your drinking. Well, why do you think that other people think you might have a problem? You're not judging them. You're not trying to force them into a change. You're just asking these neutral kinds of questions designed to raise their consciousness, to get them develop discrepancy, like getting them to see, yeah, you're right. It does seem like I'm having a harder time at work ever since I started drinking more, whatever it is, getting them to see the need for a change and to move towards making that change through the art of asking questions, rolling with the resistance, having that space of developing empathy and like, hey, I'm on your side here. I'm not trying to make you do anything, but can we look at this together?
Yeah. Great. Yeah, that's perfect. That's really, really helpful. Okay, so let's take that. So we have, I mean, viewers, listeners, either, I'm going to suggest that they're either dealing with some sort of addiction themselves,
Mhm.
or maybe friend or family, somebody in their circle, or their clients. I mean, it's going to be probably predominantly these categories. And through the practitioner lens, because that's going to be most of the people watching here, students or practitioners that use EP and especially EFT.
Mhm.
Let's talk a little bit about that. The aspect of kind of working with addiction, knowing that 90% of the time there's trauma underneath that. Let's talk a little bit about EFT protocols. I know, and we had spoken about this previously when we chatted, that when we start to look using EFT as a primary modality, what might be some tips you might give as maybe an order of what you're exploring? Do you necessarily work with cravings before you work with how the addiction's showing up in problem, and then you work to trauma, and then you might use certain protocols? Like, I really want to see, and I know it's your perspective, but it's your clinical practice in working with people with addictions and trauma. What have you learned? What would you like to share about that?
Yeah, and I think it's a broad question because obviously we have different types of
Of
settings. We
course,
have
of
like
course.
the private practice office, one-on-one. We have group, therapy, or we have part of a whole program like what we do at
Right.
rehab. So, I mean, but I think in general, the principles is you got to give a lot of education, a lot of psychoeducation. Like, how does addiction work? Like, why do you get addicted to things? What is the biology of trauma? Like, I feel there's a lot of foundational work that we need to do before we get too deep into, especially like deeper processing. So giving education, this is what, like, I'll do a 2-part in the EP group, a 2-part intro to the biology of trauma. And I'll first, teach the fight, flight, freeze, the amygdala. And then the second part is polyvagal theory. And I'll teach
Great.
about how all that works. And so the groundwork I'm laying is, look, you have a brain that gets hijacked by this fight, flight, freeze response, and we got to teach you other ways to manage that besides the drugs and alcohol or other behaviors you're doing that aren't really working for you. And you also have to recognize they're not really working for you, for people to be receptive. So you're giving them a lot of education. And then I start with the emotional 101. When I actually teach tapping for the first time, I don't even get into the words. I actually am really, and we usually teach a lot with breathing techniques and mindfulness as well. So I'm doing like a mindfulness meditation check in. What do you notice in your body? What are you thinking right now? What are you feeling right now? And then rate it on a scale of 0 to 10 with the overall, units of distress. And then let's just tap and breathe, right? Tap on each point. I show them the points. Let's take a deep breath. And that's like the simplest version. And I have them have the experience of, oh, I was feeling stressed out at a 8 out of 10, and now it's at a 5 or 6 out of 10. That's pretty cool. Now you've got some buy-in because they've had the experience of, oh, I've calmed myself down a bit. That's kind of interesting. And then I might go into cravings. What's it like when you feel like you have a craving to do the behavior or engage in the addiction, right? What's that like? And when I do it in a group, I write out everything everyone says on the board. And then I start maybe with a script, right? And I start explaining, even though I said the setup statements, right? And I talk about how we want to kind of start tapping on the negatives first. And then maybe we move into the maybes and what if this could change. And then we can get into affirmations. What would you like instead? And so I'm sort of setting them up again for that emotional first aid. I'm teaching them how to deal with a craving when it comes up. And then we can get into the deeper work. Okay, well, what are the core beliefs you developed, throughout your life that make you think that you don't deserve to have a happy life free of addiction? If it's like you get triggered in your interpersonal relationships with people, maybe there's some attachment issues, there's some wounding, there's some inner child work or some parts work. Maybe we need to do the deeper trauma processing with tapping or with brain spotting. And so it's a kind of a build up to that. I don't think I would start unless someone came into my practice or came to the rehab that I had worked with before, or who I knew had done this work before or had worked with another practitioner. Then maybe we jump in a little quicker because they already
Okay.
know the basics, and now I'm there to take them further than they've been able to go before. So you kind of have to assess, where is the client in all of this? what is their stage of change, what has worked for them and what hasn't. Because there you'll get people, a lot of people show up at rehab and say, oh yeah, I tried that tapping thing in the past, it didn't work. Well,
Right.
sometimes they're not even referring to EFT, they're referring to the tapping from EMDR, and they don't know I'm even talking about something completely different, or they maybe didn't have a practitioner that really knew what they were doing, or
Right.
whatever it is. And so understanding, like very thoroughly assessing where are they coming from, what has worked, what hasn't, and what do they want as their goal. I might have abstinence as a goal for them, but might not be, the harm reduction concept comes into play here. Some people don't want to be completely abstinent from an addictive behavior, they just want to cut back. And so we might take a harm reduction approach in that case.
Great. Yeah.
So along this same line, this is so fascinating. This is great. So what EFT techniques would you use for like self-regulation, deeper trauma processing, sort of which techniques do you find get used?
Yeah, I mean, I think I like the tapping and breathing, to maximize the effect for just like calming your nerves, especially if you're in a real full-blown panic attack, fight, flight thing. You can't even think of the words, like forget about words. Just tap and breathe, and then, or maybe it's tune in. I do teach that sort of holistic, check in with your body, check in with your head, check in with your emotions, and like tap on those things that you notice in each of those areas, right? But specifically like with trauma work, the movie technique can be very helpful if you're dealing with like a single event. I did this with a lady who came into my practice with a really severe car accident. So we did the movie technique over 3 sessions, and that completely, extinguished her trauma responses. I mean, she couldn't even begin to tell me the story without the shaking and the crying and her body kind of contracting and in pain. By the end of the 3 sessions, she could tell me the whole story, go through the movie with no activation whatsoever. So that's a good one. You got a lot of clients who are real talkers, and so tell the story. Let's just tap as you're telling me about it. That can be helpful. We get a lot of the people are afraid to go there. This is a big one with trauma. Like, I don't want to touch a trauma because they decided at a young age, especially if it was early life trauma, their inner child self, decided, I can't handle this. This is too much. And so even opening Pandora's box, I know I need to do the trauma work, but I'm too scared. So the sneaking up on and the sneaking away, like those strategies are helpful.
Yeah.
And sometimes you really have to work with that fear. Like, even though I'm so scared of opening up this trauma history, I know I'm not alone. I know I have my therapist, have my support group, whatever. We might have to set it up a little bit to even approach the trauma, because they've got a whole set of beliefs and resistance and fear and psychological reversals. That's a big piece of it too, right? Around even going there and making the change.
Yeah. Gary Craig would say anytime you have an addiction, there's always psychological reversals. There's reasons for not letting go.
Yeah.
Do you do, with that piece, because you mentioned it, any insight for people that might be working with groups as opposed to individual? Either safeguards or things you wouldn't do with a group, just...
Yeah. I'm not getting too deep into trauma processing. So when I say like sometimes we'll show videos from the Tapping World Summit, right? And they'll say, pick a situation you're feeling really anxious about. And I'll say, do not pick your deepest, darkest trauma. Okay. Pick something especially in the beginning, if I'm just teaching it, pick something like level 5 stressor, kind of mid-range. Don't pick the most. So I don't want them getting destabilized and like overly activated in group.
Right.
So if it happens, it's sort of good for the people to see how you could use tapping, for example, with someone in a panic attack and help them get out of it. But it also can activate the other people in the group, right? And this is the way we run groups in general, even if they're not EP groups, like just a regular process group, a CBT group. People can become dysregulated just talking about whatever with some other modality, and you may need to pause the whole group and let's all take some breaths. Maybe we do some paced breathing, or we do some tapping to get the whole group de-escalated, because they will feed off each other. Most of these clients are highly sensitive empaths. If one person is feeling really anxious or angry, the others tend to get activated also. So I think managing this, like I would suggest to people, have some expertise in knowing how to use these tools with one-on-one clients before you start trying to do it in a group, because it's a lot more to manage.
Yeah. And I really want to appreciate your emphasis from the very beginning of, especially with addicted clients, is teaching them how to self-regulate. Because they're going to spend a lot more time by themselves dealing with their cravings and their needs and the implications and the consequences of all of that between now and the next time you see them, that if you're not giving them tools to be able to self-administer, it's not going to be nearly as effective. So thank you for that.
No, and you actually, it's for also retention and treatment. I mean, you know, if you're working in a treatment program, you know, people constantly, especially in the early stages when they're first getting off, they're in detox and they're first getting off drugs, they're like, I don't want to be here. I can't handle this. I got to, you know, they want to AMA, you know, leave against medical advice. We've trained all our frontline staff, the RCs, the residential counselors, who are those peer recovery counselors. We taught them tapping too, and breathing and different techniques.
Right. Awesome.
You know, even the ice in the hands, you know, the tip skills from DBT. We taught them all that so that they can help the client, like, let's just breathe. You and I together, it's co-regulating, right? Let's
Right.
You and I together breathe or tap. You're freaking out right now. It's okay. I felt this way too when I was getting sober, you know, and just sort of like building up, like, you can do this. Remember why you wanted to do this for your kids. You wanted to become a sober mom for your kids. Remember that, right? And like, we help them through those rough spots, or when they have the like social anxiety. Oh, we're going to a 12-step meeting. I'm going to be around people, and they're freaking out in the van, you know, like on the way there, they can do some tapping to self-regulate. So.
Okay. So I want to hit on an really important question given this topic, and it may not be the favorite one that people want to hear about, but it's critically important. And that is regarding scope of practice.
Yeah.
That is regarding levels of care. You know, on one hand, it would be easy. Some people might say, just give me a very clear black or white. Can I do this or not do this? Because, you know, the majority of people at least in the EFT field, you know, if I had to guess, 3/4 are not licensed practitioners. So it's a lot. And, you know, it's one thing somebody coming to you to trying to curb, you know, their alcohol intake. It's another thing to work with somebody that's trying to cut back, even quit smoking. It's very different than somebody with a cocaine addiction. It's very different with somebody than necessarily with sexual addiction. I know that predominantly you're substance and not behavioral. But I'd love to hear your perspective as being somebody in the field whose, you know, responsibility is what's in the best interest of clients. But I'd love you to talk a little bit about both scope of practice, expertise, not because somebody's licensed are they trauma informed, and not because somebody's a licensed practitioner or they addiction trained, and not because. So, you know, there are lots of kind of overlapping bubbles here, and I'd love if you would speak from your perspective about that.
Yeah, I agree. And I think this is a very broad topic and a lot of considerations, but like always keeping it within an ethical framework. That's the key, right? Like, ethics is about what is in the best interest for everyone involved. Client, of course, first and foremost, but practitioner as well, because we have to keep in mind, you know, the possibility of vicarious traumatization or compassion fatigue or burnout. Like, these are real things that happen to people in the helping professions, not just licensed people. So just your own well-being, of course, is super important, and having your own self-care and all of that, and knowing that, look, if you have a real difficult response to hearing people's trauma stories. I mean, I listen to horrific things all day long. If I didn't have the tools to be able to do this, regardless of my licensure, I would not consider it ethically sound for me to do this type of work. Okay. If I have my own unresolved trauma that gets activated when I hear someone else's trauma, I might not be ready yet. I might need to go do my own work before I can really do this type of work with others. So I think it starts with screening first and foremost, like really getting a clear assessment of what is the client's background? What are they coming to the table with? Have they ever done any of this work before? Do they have any emotional self-regulation tools? And this is particularly in the one-on-one, you know, coaching, therapy, office kind of setting. What is the extent of the trauma? How much does it impact them? Do they dissociate? Do they have panic attacks? Like, I think having a really good questionnaire assessment form, you know, that you go through where you ask all these questions, because then you'll get an understanding of, can I work with this? If the client tells you, I lose time, I dissociate, I lose time, or I have full-blown panic attacks every day or a few times a week, then those are red flags that they're likely to do those things in session with you. And this is where I would say, if you have not really had the specific training for dealing with someone in the midst of a panic attack, or who is dissociated, and maybe another personality or part has come out, which happens a lot with trauma, right? Especially early ritualistic abuse and all that. DID has a huge overlap. Dissociative identity disorder has a huge overlap with PTSD and trauma from early childhood abuse, especially ritual or cult abuse, that kind of thing. Knowing your person might have that in their background, that could be over your head. At that point, I would refer to a specialist. If you have not worked with that issue before, you're ethically, I think, bound to either get training in that and supervision in that, or refer out to somebody who does have that expertise.
Yes, and thank you for saying supervision.
Yeah.
Yeah.
Consultation, supervision. I often do get, I am a consultant, right? So other practitioners will come to me to learn about how do I work. And of course, our own staff, right? And I supervise associates who are not yet licensed. It's always about consultation, supervision, how I, with my expertise, can help you become more knowledgeable about how to work with folks. It's not a rule out. It doesn't mean that just because you don't have a license, you can't do this. But there are parameters, and you just have to kind of take it case by case. It's hard to make black or white rules around it.
Yeah.
Right. Perfect. Yeah. Thank you so much. And also, I want to say there's private practice as one intervention, but there's various levels of intensity of what somebody might require beyond whatever therapeutic technique you're administering. Could you just speak to that for those people that aren't aware? Maybe some of those.
And especially if you're going to work in addiction, if you've decided you want to specialize in treating this, you really need to learn some the ASAM patient placement criteria. ASAM is the American Society of Addiction Medicine, and many years ago they came up with these kind of like what the old the five axes, axis 1, axis 2, similar to that. There's 6 dimensions across which we rate the severity of somebody's presentation of their symptoms. And, it's everything from their detox or continued use risk, right? Because people coming off of certain drugs like benzodiazepines or alcohol, they can have seizures, they can have DTs, they can have life-threatening conditions. So you need to be really clear on how much are you using, what are you using, and knowing kind of like the safety risks of cold turkey stopping versus you might need to go to a detox program. You might even need to even sometimes we get people, we have to send them to the hospital. They are so unstable and at risk of one of these conditions that we might need to hospitalize them, and the hospital needs to treat them, and then they can come to detox. And then underneath detox, you have residential treatment. So that's your 30-day, 60-day, you live at the program, you do these groups and individual therapy. And then underneath that is outpatient programs. PHP, partial hospitalization. That's like going to school. You go 5 hours a day, more groups and therapies and things, but you live at home or you live in a sober living house. Intensive outpatient, PHP is 20 hours a week. Intensive outpatient is a step below that. That's 9 hours a week, usually 3 hours over 3 days. Then underneath that, you have outpatient. That might be a group or individual therapy alone, So these different levels of care, and the patient placement criteria, and you include mental health in that, and you include the environment they're in that, and they're biomedical. There could be a compromised, physical health issue. You look at all of those factors to determine what is the right level of care. And some people have to go to the very top and over time work their way, step down through the different levels as they get stronger. And some people are coming up. Some people are like, well, I don't know if I need to go to rehab for 30 days. Maybe I should go to an outpatient program and see if that will help me to curb or stop my behavior. And if that's not working at that level of care, I need to go up one more. But to think that you're going to deal with somebody, and people are naive about it, the clients and clinicians, to think that you're going to deal with someone who, let's say, is doing cocaine, doing an 8-ball, every couple days, and they're round the clock, I'm not sure I'm going to treat that person in my private practice at that stage of it. Mm-hmm. That seems unsafe to me.
And
Yeah.
especially because you do it is the co-occurrence of mental health diagnoses and addiction simultaneously, which just is a whole different ball of wax.
They might need medications to get off the drugs they're already on. They might need medications, mental health medications to stabilize, because now they're not going to be sleeping. Now they're going to be, you know, or maybe they're going to get suicidal coming down off that cocaine or meth, right? People can get suicide. So it's very, really understanding the science behind it and understanding the risks involved and not taking on a client. I learned the hard way not to take a client into my individual therapy practice that really needed a higher level of care.
Great. Thank you.
Thank you. That's so helpful. Thank you.
Mhm.
So other area that we'd like to cover with you is that you mentioned earlier when we talked about the work of TJ Woodward in conscious recovery and core false beliefs that lie at the heart of much addiction. So could you talk to that for a little bit? Thank you so much.
I love TJ. So TJ Woodward and I worked together at a rehab program many years ago, and we really were taken, you know, everyone was so busy pathologizing the clients, our fellow professionals. What's their diagnosis? What's wrong with them? What pills do we need to give them? And yes, that's all important, but they were so focused on the pathologies that they were not focused on the strengths. And TJ had been the spiritual counselor at this rehab program, and I was a therapist at the time. And we were looking at like the holistic. Well, what about the spiritual side of things? You're just looking at the biology, you know, and the psychology. What about the spiritual side of it? And what about what's right with people already, you know, instead of what's wrong with them? So he wrote this beautiful book called Conscious Recovery. Together, we co-authored the workbook for it, and we created a whole curriculum that is taught in various rehab programs around the country and starting to go around the world. And you know, all our clients who come to Avery Lane, they get the book and workbook, and then we teach groups in it with this curriculum. And essentially what he's talking about is there are 3 root causes of addiction beyond the biological and all of that stuff. And it's unresolved trauma, toxic shame, and spiritual disconnection, which really refers to, first and foremost, disconnecting from your own essence, your spirit, your authentic self, you know, the being you were born into the world being, you know, like when you look in the eyes of a baby or a small child and they're just joyful and happy and present in this moment and not worrying about the future, dwelling on the past, just being, right? That's your essence. And we get disconnected from that through our traumas, through the messages we get, and the core false beliefs weaves through all of this. It's like we get these messages from so early in life, or we come to these conclusions about ourselves and the world that are fundamentally false and go against our true essence, our true spiritual nature. So things like, I'm not lovable, I don't deserve to be happy, I'm a bad person, everyone's against me, I'm never going to succeed in life. All these core beliefs that become like the MO of how people function in the world, right? Becomes your programming of how you operate. They're fundamentally false. And if you believe them to be true, you're going to attract people, places, and things to you that are going to mirror back the truth of that. And sometimes you get those messages overtly through programming at school, religion, you know, the messages you get from social media and the movies and the peers and your family and all that kind of thing. This is how you're supposed to look. This is how you're supposed to act. Little girls do this. Little boys don't do that. All those messages, those programs. And sometimes it comes from abuse. Sometimes you're told these things. Oh, you're fat, you're ugly, you're not, you know, and you as a child don't know any different. You come to believe them. Bruce Lipton talks about, you know, up until the age of 7, we're basically in a hypnotized theta wavelength, you know, brain state. So we're being hypnotized by all that's coming at us, and we learn a lot of false things. And so these are really some of the focus of that work, is really helping people to start to use spiritual principles to unlearn those core false beliefs, and to reconnect with that essential self, to remember who we truly are, and practice, you know, spiritual principles like non-judgment, non-resistance, the power of the question, living in the question, the power of forgiveness, compassion, gratitude, how we can use these things as part of, you know, the larger program of all the other tools, you know, as part of a healing process, as part of recovery.
You're setting the standard really high.
I know.
I mean, and it's fabulous. And it's
Thank you.
wonderful.
Well,
And
we've gotten really to speak to that, Craig. Like
yeah.
we actually, and that's what I wrote in the paper for the EP journal. We actually have won an award 2 years in a row. Avery Lane has, where we have the best outcomes. So we contract with this company called Vista Research, and all our clients, they do these standardized instruments on depression, anxiety, PTSD, right? They do them like every week while they're in treatment, so we can see if they're improving, cravings, all different things. And then they follow up once the clients leave treatment. This company follows up with them 30 days, 3 months, 6 months, a year. I don't know. They have different increments. And our program, when compared to, I don't know, thousands of other clients and other treatment programs across the country, our clients are doing significantly better in maintaining sobriety at the year mark. And listen, the rates are still low. I think our rate is about 49% of our clients are still sober. So I
That's
think it's
amazing.
important for anyone doing this work and who's trying to get maybe recover from an addiction. Relapse is kind of a normal part of the process. We expect it. Not everyone is successful on their first attempt at changing an addictive behavior.
Yeah, no, thank you for that. And, do you see, what do I want to say? I wish every practitioner here had a treatment center, so when they had somebody that's addicted that they could refer to like yours, but they're generally in person and not online clinics because of licensure, et cetera. Are you seeing, if we look at the wave, I mean, for me personally, it would be the next big wave that I would love to see EFT influencing is the field of addiction with more and more practitioners. We've trained an addictions-based clinic on the East Coast, but it seems like it's such a very small percentage. And I'm just curious, professionally, maybe the state of affairs, what you're seeing, the trend, what you're hoping, maybe you could just speak on that. And what's needed to maybe expand it as well.
Yeah, it's moving in that direction. So that's a good sign. I think the fact that we have the science now, 20 years ago when I would talk about energy psychology, people thought I was some weird woo-woo lady from California, hippie chick. Like, what do you, there wasn't a lot of credibility. And especially when we were using the language of blockages and the meridians and the chi and the traditional approach is wonderful, but like a lot of people didn't buy it. Now, when I talk about, Harvard did a 10-year research study, Harvard Medical School did a 10-year research study on acupuncture that essentially validated it. And we can see with brain imaging, like what happens to someone's brain before and after using EFT. I love showing Peter Stapleton's TED Talk on EFT for cravings. Clients see that and they're like, I want to try that. That looks great. There's science behind it. Great. People are more receptive now. So that's helping, and the evidence-based stuff, all the research that's been done, all of ACEP's efforts to get, the APA and other organizations on board, having the VA approve it. Like once you get the bureaucracies to say, this is a safe practice, it is evidence-based, that helps. And then, more and more, I'm getting clients coming into treatment saying, I've heard of that tapping thing before. You've got some mainstream stuff, it was on Good Morning America, it's on this show, that show. So that's helping. And more, you're seeing presentations at conferences, I myself being one of them. I've spoken at a number of now addiction counselors. I did an EP presentation there. I spoke at a huge conference just in November called GXC. It's the Global Exchange Conference, all for addiction, mental health, and wellness. And people are curious. People showed up at my talk. How do you use energy psychology in addiction treatment? How can you do this? So it's going there.
Thank you. We have just a few minutes left, and Suzanne, there was another question that you wanted to ask, and we do have time for it. Yeah.
Yes, I would be curious to hear what you had to say about working with specific populations, or at least considerations when working with diversity in the individuals that may present with addiction.
For sure, because there are for sure issues, anything from LGBTQ and the rest, different ethnic groups or races. The way people view mental health across cultures is really different. Get training, diversity and DEI training, diversity and
equity and inclusion.
Equity and inclusion. Yes, thank you. Get the training, get consultation supervision, right? If this same as we talked about with scope of practice, if you have never worked with this kind of group before, it doesn't mean you can't, but you want to get training, supervision, whatever you can, and then be open with the client, say, hey, I haven't actually worked with someone like this before. Would you be willing to help me learn? Or what would you find beneficial? Like in some cultures, like it may be that the family comes to the therapy session with the client, and that's expected. We have to be very careful of being biased with our Western rugged individualists. Like, I'm just treating the client, I don't care about their family. Like, we have to be really mindful of that. And especially in some of the Eastern cultures, individualism in general is considered inappropriate. It's selfish. So you have to work within the context of people's belief systems. And if you don't know about them, ask, learn, find out. And if you, again, are in over your head, or the client is really wanting, like, it can even happen that some clients with addictions don't want to work with someone who's not also in recovery.
Right.
They have this belief that you don't understand what I've been through because you haven't been through it. So talking with the client around, like, can we make this work? And if not, can I refer you to someone who is more expert in this area?
Perfect. That was awesome. That was beautiful. Thank you so much. And Avery Lane is still an active working clinic. You're still doing lecturing and writing and out there. And thank you for being the voice of EFT and EP out there, because it really takes people that they feel this is part of my tribe, and there's a respect and an honoring for somebody that's a part of us that's talking about the advantages, and that's how things are going to change and grow. So thank you for taking the time out to meet with us in advance and for today, and just so appreciating for your research. We'll have a link to your paper and on your website for people who want your book and all of that. So, or supervision or whatever.
Consultation, yeah.
Consultation, yeah.
Sure,
So thank you so much. Yeah. This was
and I do have a book that's going to come out, if I can give a little plug. I'm working on a book for EFT for addiction. It's going to be part of the EFT Universe series. Dawson Church's work, the EFT manual, EFT for PTSD and all that. It's going to be in that same format. Hopefully coming out sometime in 2024. I'm still working hard on it, but I'm really excited for that. And that is really for both the professionals working with folks with addictions, as well as people who have addictions themselves. It's really oriented for both. So I'm really excited for that to come out.
Great. Nice resource that we're going to have for sure.
Well done. Great.
And speaking of resources, we are about to start our next round of tapping out of trauma. And so
every spring, every fall, this always in March. So we have the spring coming up in March, and then always again in September through the fall. So, there'll be plenty of, you'll get a follow-up, just information about that. And
you can always check in on our website, tappingoutoftrauma.com.
Right. Yeah. So I hope you'll join us. And this is the kind of quality that hopefully you will always continue to find as we continue this year after year, which we love doing. So everybody, thank you. Have a beautiful rest of your day. And to all the viewers, we hope it was helpful and useful for you and yourself and for your clients and patients. So thank you.
Thank you.